Thank you, Padma, for giving me this opportunity. I'll be presenting a case of retinal vasculitis. Retinal vasculitis is inflammation of the inner plexiform layer of the retina blood vessels. And um, uh, periphlebitis is more common than periarteritis. Let us discuss a case. This is a 28-year-old male complained of floaters and redness decrease in the vision since 2 months. Base corrected visual acuity was very less, 660 N36 in the less than N36 in the right eye and 618 N36 in the left eye. Investigations was done elsewhere, but not by us, and which for sarcoid, QTB, syphilis, and HIV was negative. And this was the typical mouth ulcer, leg ulcer, erythema nodosum. He had also genital ulcer. And the fundus examination showed vitreous haze. And if you look carefully, there are few retinal infiltrate were seen, retinitis lesions were seen in the right eye. Left eye also has shown retinal infiltrate. But fundus fluorescent angiogram is quite amazing with a extensive gross capillary farming in both eyes, right and left eye. And OCT showed a neurosensory defect in the right eye. Left eye has some little wrinkling of the internal limiting membrane. Optical coherence tomography showed flow void areas in the both superficial and deep capillary plexus. With this, we made a diagnosis of Biswas disease. Chronic relapsing occlusive vasculitis, unknown etiology, and pan-uveitis. We treated the patients with initially cyclosporine, azathioprine, and prednisolone. There was not much improvement. Then we put the patient on biologic injection adalimumab subcutaneously. Patient had 4 injections of adalimumab. There was some improvement of the vision, but could not continue for further financial constraints. When he came back, vitritis was not there much, but there is a retinitis was again seen. He was again put on biologic agents, and this is a capillary farming on fluorescent angiogram. So this is when you diagnose a Biswas disease, you need at least 2 criteria of oral aphthous, general aphthous, erythema nodosum, and ocular involvement, anti-uveitis, post-uveitis, and retinal vasculitis. Other sign can be arterial thrombosis, large vein thrombosis, phlebitis. FFA should show capillary farming. And the treatment is the immunosuppressive, and now biologics has come with the corticosteroids. We published a clinical profile and management of immunosuppressive and biologics in Biswas disease, recent issue of May issue of Indian Journal of Ophthalmology. Majority of the patients were male, and posterior uveitis is the most common finding, followed by pan-uveitis. And we treated with the steroid and immunosuppressive or steroid with the biologics in majority of the cases. Those patients which are treated with the steroids, immunosuppressive and biologics, they showed good improvement of the vision. And this is a patient, another patient with a cyclosporine therapy showing resolution. And we published 18 cases of biologic therapy in 2020. One of the patients has Biswas disease who had with the injection adalimumab, there is a significant resolution of inflammation. So just few points about retinal vasculitis. The question I ask, is it retinal vasculitis alone? Is it ocular alone? Is it associated with a systemic disease, autoimmune, infective? Primary and idiopathic retinal vasculitis. EOS disease is now thought to be an immune-mediated reaction to the Mycobacterium tuberculosis, associated with uveitis, associated with collagen disease, associated with infection, associated with neurologic disease. Top on there is the syphilis, next is the cytomegalovirus retinitis, and you can see sarcoidosis, candleworks, dripping, skip lesions of retinal vasculitis. ERN can also have retinal vasculitis, like also tuberculosis, toxoplasmosis, acute retinal necrosis. Collagen disease, systemic lupus erythematosus, can have exudates with retinal vasculitis and hemorrhages. Fluorescent angiogram is quite characteristic with gross capillary non-perfusion. Multiple sclerosis can have retinal vasculitis. We have described a case of retinal vasculitis, multiple sclerosis. In conclusion, retinal vasculitis needs a systematic approach, can occur due to various causes, needs systemic and laboratory investigations to be often managed with consultation of an internist. Thank you.
Thank you, Dr. Biswas. So just for the benefit of the audience, what is your battery of tests that you order when you see a case of vasculitis? Patient has no, systemic history, absolutely normal, healthy. What is the battery of tests?
I do Mantu, quantiferon, ceramacin, VDRL and TPHA and ANA testing, the anti-double stranded DNA.
These are the standard tests that you would order in all cases of vasculitis. The other, you had a very interesting case of Behçet's, sir. So before starting azathioprine, do you order the TPMT test? So
no, I don't do.
TPMT test you don't order. So
even this is costly, and then even if TPMT is positive, that doesn't really negative. That doesn't really guarantee that they produce that bone marrow
and for
suppression.
Behçet's, your first choice of immunosuppressive is azathioprine, if I understand right.
Hence,
Okay, thank you, sir. Dr. McCluskey, we would like your comments on this.
Yeah, I think it's a beautiful case, and I think that tree ferning pattern on the angiogram is really typical of what you see in Behçet's disease.
Yeah.
And that's really one of the treatment endpoints in treating that disease, is to dry out the angiogram to make sure you get rid of that vasculitis. I guess the only other thing in my experience, Dr. JB, do you have a different differential if it's occlusive retinal vasculitis as opposed to that leaky type that you showed with the Behçet's case?
Occlusive retinal vasculitis, I keep the possibility of Eales disease, which is a tubercular retinal vasculitis. And I do an angiogram, and angiogram shows veno-venous shunt, capillary tortuosity, and the vascular abnormality, capillary non-perfusion is much more predominant in case of Eales disease, and they predominantly involves the periphery. Central area is really spared mostly.
I mean, that's certainly our experience in Sydney, that occlusive vasculitis is usually either TB related or Behçet's related, and whereas there's a much broader differential diagnosis for the non-occlusive.
They don't have occlusive vasculitis mostly doesn't have anti-uveitis. Behçet's will have.